thank you very much for this kind introduction. And as one of the last presentations standing between you and lunch, I welcome you to the presentation about the development of validated methods to generate haptic feedbacks, especially in soft tissue. We will run through the main points once. I first want to talk about the status quo. Then I'll continue with the project concept for this simulator. And finally, I will give you a short outlook on the results, where you see some part of our working status. This simulator is basically built for epidural and spinal needle, epidural and spinal anesthesia, as well as for lumbar puncture. We already heard that these procedures are mainly carried out blind. Blind means that you, in this case, have no imaging modality available, so no ultrasound, no X-ray, and all that stuff. So you really need to rely on the haptic feedback you get from the patient. What is now actually epidural or spinal anesthesia? I just explain it quite short. A needle is inserted from the back of the patient. As what you can see here are 3 vertebrae. And a needle is inserted from the back of the patient, who is either positioned laterally or in a sitting posture, into the epidural space, or between, first of all, between 2 vertebrae, between 2 spinal processi, and the goal is to reach the epidural space, or for example, in epidural anesthesia. There he needs to pass some special ligaments which provide him with different haptic feedback. First of them is the ligamentum supraspinale, which is one of the first haptic feedback courses. Then he continues through the ligamentum intraspinale, reaches the ligamentum flavum, where he gets a last strong feedback. It's a really strong and hard ligament. And after passing this ligament, he needs to stop the needle advancement to stay in the epidural space and not proceed further to maybe accidentally hit the dura. Or as it, for example, in epidural anesthesia here he needs to stop. In spinal anesthesia and lumbar puncture he needs to advance further into the dura, lumbar puncture in order to receive some cerebrospinal fluid, and in spinal anesthesia in order to apply some anesthetics there. I showed you now the midway to perform this procedure. There is also a second approach, the paramedian way, where you go not directly to the first 2 ligaments. Instead, you get to the muscles and to the connective tissue and approach to the ligamentum flavum and then to the epidural space. But that's just additional information. So how many cases do we basically have in epidural anesthesia or analgesia? There are 2 studies I found. First was with 12,600 and the second in 9 hospitals around Europe. Second was with about 700,000 epidural and spinal anesthesias in 309 hospitals. If we look on the complications that might occur and the rates, the percentage that might occur here, we get up to 12.7% in technical complications, also including 0.7 or 0.6% dural perforations. So as my supervisor, Andreas Schrempf, already pointed out, the learning curve for epidural anesthesia, I would like to focus first on the first 20 approaches, where we have a very steep rise here. So after about 20 performed procedures, we get up to a percentage of 60% of success rate. And we want to address exactly these, or we want to deal exactly with these 20 procedures and have a look on them in detail. So how are these 20 procedures normally performed? So how are they carried out in our life? Skills training today works here also with the approach see one, do one, teach one. which is not quite good for patient safety, as well as gives no, or at least hard quantitative feedback of the actual success. The next thing would be the training on human specimen, where we have some difficulties here because despite the ethic concerns, we also have difficulties here because of we need a wet lab or we need a sterile environment. And if we work with formalin fixated specimens, formalin also changes the haptics of the specimen. So it's basically not even comparable anymore. And the last part are simulators that are used today. So these concentrate on either mannequins or virtual reality systems. Mannequins, you also had the greengrocer simulator already in a presentation. This would be also the first simulator for these procedures. It's basically a banana where you can feel the force drop while puncturing the hull of the banana. Yep, and also the mannequins leak of the quantification of the success. So what are our project concepts? Let's run to the project concept. We want to generate a hybrid simulator which covers the haptic feedback, the choosing of the insertion point, which is crucial for this procedure. If you choose the wrong insertion point, it for sure will not work. Then we have real-time tracking of the instrument, which allows us a quantitative feedback once for the trainee and the other side also for a supervisor of the trainee. So let's have a look on the haptic feedback. We here have a force curve measured while needle insertion in patients recorded by Peter Brett and his colleagues. And you already see here two defined spikes, region 1 and region 2. Region 1 would cover the supraspinal ligament we've talked before, and region 2, which is a bit broader also, would model the ligamentum flavum, so the second very strong ligament, which is just in front of the epidural space. After the penetration of the ligamentum flavum, a very steep force drop is experienced, and this force drop is also, as we said, the signal for a surgeon to stop, or for an aesthetician to stop. Despite these first curves, we also did or planned, no, we did actually till now, some force measurements on human specimen in the BGU Murnau. Here on this picture you can see how we did it. We have a test bench which can be controlled with a defined feed rate, and we also had some X-ray imaging to verify in which depth and in which tissue we actually experience which force by now. These, for example, would be one of our measurement curves in the human specimens, where the blue line, or each broad gray line indicates one X-ray picture, and in the blue line you see this X-ray picture, which is now just in front of the ligamentum flavum, or actually in the ligamentum flavum, as we saw. To implement the free choosing of the insertion point, we plan to do a whole patient phantom, which is going from T7 down till L5, which can vary in position. So also the most realistic behavior of the phantom could be modeled. The tracking of the instruments you already saw in previous presentations. We work with our electromagnetic tracking system. It's not implemented till now for this simulator, but here you see it implemented for one of the simulators for the approaching into a vertebra. Also with the simulated imaging modality behind. And finally, I want to give you a short outlook on our working stages, and they're basically about the haptic feedback. Here you can see our model of the, in this picture, just 2 vertebral blocks, and me inserting a needle and trying to aim for the epidural space. As you can see, you can also have here region 1, region 2, and region 3 modeled. And this curve, the first curve which you see here, was again recorded with a test bench with a feed rate of 1 millimeter per second, and therefore also comparable to the measurements of Peter Pratt et al. And to our measurements we did on the human specimen. We don't only do stuff as we think they are, we also talk to the clinicians and ask them what they think about the stuff we develop. And therefore here we have not the validation results, but some evaluation results about how they liked our Phantom block. So no tracking till now, no finished hybrid simulator, just the Phantom. And they already said it's quite suitable as epidural simulator. But just to keep in mind, these were just 9 anesthesians in 1 clinic, and up to now we are doing a validation study which is conducted in 3 different hospitals, 2 of them in Austria and 1 in Bavaria. I want to thank the Kepler University Clinic and the Biomechanic Institute in Murnau in Bavaria for their cooperation, as well as the FFG, which gave us the funding for this project. So if you have any questions now, please don't hesitate to ask. And yeah.
Hello. This question actually applies to any of the previous speakers. I can see the applications for developing, the technical and the psychomotor skills of clinicians, but there's always that balance between that and the behavioral and the attitudinal skills that are needed to create overall clinical competence, developing the temperament of the surgeon and the temperament of the anesthetist. How can this be measured? Because ultimately, you need to have that connect with your patient. And one of the disadvantages of these procedures is that there's a disconnect with the living human patient. And you might become quite cavalier in practicing on a subject that is not human versus the ultimate subject that you will practice in the human situation. How can that be measured?
Up to now, we have not implemented this in our kind of simulators because we try to give opportunities to train the skills for actually approaching or for actually penetrating the Phantom, or for actually penetrating a patient with a needle. But we didn't now cover the part with the interaction with the patient. We also have, during the conduction of our validation, we now had the impression from the clinicals that they also want a kind of simulator that is interacting with them. So we really have this feedback also, but till now not implemented. Yeah.
So, thank you. Maybe to sum it up, of course, if you concern on skills training on a simulator, the simulator is not able to represent a person which you can talk with. So of course, maybe if you talk so, if you want, this is a drawback of a simulator. But on the other hand, you can get a lot of skills. You can improve your skills. And I think the simulator is not going to replace the education on a patient. But at least the first steps of the education can be done on the simulator to be sure when the medical expert is coming to the patient, he has the skills, okay? So it's not a replacement, but it's a first stage in order to assure it.
Complementing that answer, I think you're completely right. You're giving a technology to use not in human beings, but in a simulated world. But also, the good thing, what we found at our university is that you can simulate the pressure of being with a real patient by using Hessel cameras and putting some time into the medical doctors. But it's always, what we found also is it's always better to try with simulated aspects and do it as many times as you can, and eventually we hope that in the real time that you do it better. So it is a very, very helpful tool. All things you've done are very helpful for the medical profession in general, I think. Thank you.
Yeah, thank you.